Ryan Stanton here with ASAP Frontline, and today a special live in-person here in Dallas, Texas at the ASAP headquarters with Dr. Mashid Abir. We talked to Dr. Abir. Actually, we're going to have a two-part interview today. We talked to Dr. Abir a few weeks ago with regard to the RAND report and that information coming out about emergency medicine. And Dr. Abir is one of the senior physician policy researchers at RAND, focusing on emergency medicine, also still an active emergency physician. So first and foremost, now that we're face-to-face and not over Zoom, give us a little background on yourself more than what I just pulled off the top of the headliner.
Yeah, absolutely. Thank you so much, Ryan. So I'm a practicing emergency physician, as you mentioned, and work at RAND as a health services and health policy researcher.
All right, so last time we talked, the RAND report was relatively new, and we just talked about what was in it, what it meant, kind of where we go from there. Since then, a few things have happened. You know, we've got the big, beautiful bill that's come through, of course, the continued policies of the current administration going into place. So kind of refocus the RAND report in terms of what's kind of happened in that interim.
Sure. So clearly, the report doesn't speak to the politics, but absolutely does to emergency care policy. And as you mentioned, Ryan, much has changed in this short time frame since the release of the report. We generated the recommendations of the report in October of 2024, and it truly feels like a couple of years have elapsed, although they really haven't. As you know, the report really focuses on, as far as emergency care payment is concerned, building a new payment model to ensure that emergency care is sufficiently compensated so that we can continue, that emergency medicine can continue to offer the services it does and the value it offers to communities across the U.S. Among the recommendations were increase in payment for Medicare and Medicaid. And clearly now we see that Medicaid payment is going to be decreased based on the bill that was recently passed, and Medicare is also potentially in peril. So given that, we really have to rethink the way that we provide care, and that instead of trying to fit care to the payment model, look at what care needs to look like in order to really kind of meet where payment is currently. So I think we need a complete revamp and rethink of how we provide emergency care.
Well, they're actually talking about now with the passage of the bill, states like Kentucky, where I live, which was an expansion state, and the potential now that with this passage and the cuts in the Medicaid on the federal side, that we may actually see significant closures of hospitals. So, many of the things that are talked about here within the strategies for sustaining emergency care in the United States, the report, is part of that risk to access and risk to care, and the fact that, just simply by cutting the funding doesn't mean people stop needing emergency care. It just means it's being unfunded. So basically, EMTALA now is becoming even more so an unfunded mandate. And I think as emergency physicians, we don't want to pull back from EMTALA. We want to have that availability and calling to take care of anybody, everywhere, anytime. But now more of this is being pushed, kind of the moving the shells, the shell game, in order to sustain the funding. And now the potential that we could literally lose access because of closing of hospitals.
Absolutely. And in fact, one of the things that the RAND report did was looking at the value of emergency care from the lens of places that have lost their emergency rooms. So we specifically looked at a community in rural California, a farming community, that had a hospital closure, and the ED that was part of that hospital obviously closed as well. And it had significant negative impact on the community that had to then travel 60 miles to get to the next closest ER. And that ER was then inundated with patients, and boarding skyrocketed, and so it's going to become a problem because it's going to affect people's health, their outcomes, and mortality at the end of the day.
It absolutely will, because of now we're taking the same problems, increasing transfer time or transition time, so delaying care, increasing the toll or impact or demands on that other facility, and then everything that comes from that. And now we're taking care of people hundreds hundreds of miles, dozens or hundreds of miles from their home and their families, because that's one thing we would see in Kentucky is when they would get transferred to a referral center is now they are many miles from home. Family can't come visit them. It's not easy to transition back. Then the logistics of getting them home. So the costs are going to increase significantly at that point while still providing, the same care, theoretically, but more delayed and potentially worse outcomes with these changes that are taking place. So with that in mind, as we sit here and discuss this report from April of this year, and now talking in July of this year, how do you think, just kind of seeing it from the idea of a wine or a cheese, how has the report aged with regard to the policies that we've seen since that time?
Well, I think that unfortunately, many of the solutions that we had suggested as far as payment is concerned, we find ourselves going in the opposite direction of what the recommendations were. However, as I alluded to at the beginning when we started chatting here, I think that instead of trying to fit care, the payment system to the care, we need to change the care so it fits the payment system. And by that I mean that you're referring to patients having to be miles and miles away from their families. I think that we need to remove care from the walls of the hospital. I think we need to take care to the communities and where the patients are at and transform our hospitals to emergency departments and ICUs, and everything else takes care of in the community. So that way you're leveraging home care, remote care, hospital at home, home nursing, that kind of care and the technology that goes along with it, so that you are really removing the burden or decreasing the burden of the actual, the emergency department and part of the hospital facility that offers critical care. And again, everything else happens in the community. So we cannot continue to think that we can provide the care that we're providing and get the pay that it deserves. So we need to change the way that we're providing care. So we need to think about it differently, I think.
And there's two methods to the approach to care. Is one, increasing the payment to where you're getting paid more to cover the cost, or you decrease the cost. And when we talk about those things such as telehealth, hospital at home, treating people and helping people, monitoring people where they are, leveraging technology. I mean, as simple as these devices we wear on our arms and things like that, that provide some of that monitoring opportunities while at a significant cost savings. There are significant opportunities there to meet people where they are in terms of the care that they're receiving. And I think that is some of the things that we have to do as emergency physicians, as a profession in general, and as a community, is to start looking and thinking outside the box, saying, hey, these are the cards that were dealt, and maybe it is a 2 and 7,
yes,
but we're going to end up having to play the hand by the time it's over. And, how do we turn that into something that is functional to where we can still do our jobs, provide our profession, and give people the best opportunities and best outcomes?
Absolutely, completely agree with that statement. And, I think another thing you asked about, how has the report aged? So the report is really focused, a part of it is, on what the federal government should be doing to sustain emergency care. But in the payment model that the report proposes, and in many of the recommendations, we really stress the role of localities, local governments, cities, and states. And I think that is more important than ever. And I think what emergency medicine needs to do at this point is very, very quickly coming up with a model at a state level in order to compensate emergency care to sustain it. And I think it's extremely time sensitive, because as Medicaid is cut and people are going to come to the emergency department more and in greater numbers, the volume is going to go up even further. And I think all the challenges that we mentioned in the report are going to get exacerbated. So I don't think that the profession can afford to wait for things to change at the federal level. I think that collectively, as a profession, folks need to come together and come up with state-based policy solutions and payment models that rely on buckets of funding that historically we have not really relied on, including large state-based employers that have a stake in keeping their employees healthy. And I think that there's many stakeholders that can be part of a solution, of a state-based payment model solution. So those are some of the things I think that emergency medicine really needs to do quickly.
And that's part of the big challenge now, is the fact that with these communities, one of the big things that's lost by cutting some of this funding and dependence on the federal government in terms of this is the access to preventive care, primary care and preventive care. I mean, we as emergency medicine struggle with the EMTALA mandate, but you talk about primary care that can't even keep the doors open now because of the abysmal payments to the point that they can't actually keep the lights on. So access to care is becoming less and less. Especially access to physician-based care is becoming more and more difficult. And now we as emergency medicine then are responding to the burden of illness and the burden of disease that comes across without the preventive measures that we see. And I think a lot of us saw some of that impact during COVID when we were seeing and diagnosing later stages of diseases, whether it's heart disease, diabetes, hypertension, or in one that I felt that significantly increased during COVID was cancer, late-stage cancer. Simply because that access to preventive care wasn't there and that responding. And so as you're mentioning, those state-based responses, but of course, just as we don't like to pull politics into RAND, into the report, which it stays very, very factual in terms of the conditions of the environment, each state has its own political environment, and so we're going to see a lot of difference that's going on. You mentioned Kentucky with the expansion. Well, now that significant risk because of the cuts that are going to come and take place. So we're here, and the discussion we're having here in just a little bit in front of our audience is going to be on some of the advocacy and policy and what we do. And so how can emergency physicians become active and become more impactful? But we can't assume it's going to fix itself. We see what happens when others make policies and rules with regard to emergency medicine. Very few people understand the environment, what we do, even within the hospital, much less so people who are not healthcare based. So as emergency physicians across the country, no matter your environment, whether it's a Kentucky, a Texas, where we are right now, a Florida, a California, wherever it may be, how do we as emergency physicians kind of get that involvement and advocacy to help with the access for our patients and the care they need to receive?
I think it goes back to grassroots movements and advocacy based on data at the state level. Mm-hmm. And I think that one of the things that emergency medicine advocacy groups can do is to provide a blueprint for policy advocacy at the state level for the profession so that emergency physicians across the nation can advocate for their patients and the profession in any state that they live. As you mentioned, Ryan, every state has differences. There's unique aspects and challenges to policy making in different states. States have different capabilities and capacities, but I think that there's probably a common denominator across all states of how you can go from a policy gap to passing laws that are going to help protect emergency care and the patients that are served. And I think that one of the roles of advocacy groups like ACEP is to be able to support the development of really policy pathways for emergency care payment at the state level.
All right, so and once again mentioned this is going to be a two-part interview, may even pull some of the stuff from our discussion later today. Closing thoughts, as now we are midway through 2025 with regard to the report, strategies for sustaining emergency care in the political environment in which we live.
I think that we need to really protect emergency care workers. And I call it emergency care workers because obviously emergency physicians, but also all other support categories and job categories that work in the emergency department. Part of sustaining emergency care, next to payment, is having the workforce to actually provide that care in a timely way with high quality. And I think that finding ways to sustain the workforce and help it grow, especially in an environment where the funding is shrinking, we need to get very creative about how to do more with less.
Yeah, a fantastic discussion. Dr. Mashid Abir, lead author in terms of the headliner from the, I won't tell Berdahl that. But right there, it's right there. Strategies for Sustaining Emergency Care in the United States. RAND report came out in April of this year. So we're going to continue the discussion right now with Carl Berdahl. And as we kind of put this into focus in terms of what we are seeing with the changes that are taking place, the politics that are taking place, with this report that really outlines and puts to paper what each one of us is feeling in the emergency department every single day. So welcome back. Joined now by Dr. Carl Berdahl, and we talked to Dr. Abir, and we had the interview as the RAND report came out in April. Now we've got the big, beautiful bill that has gone through and had this discussion this morning. So kind of dive into that interim of the last 3 months of what we've experienced and seen from your standpoint as one of the major contributors to this report on emergency medicine.
Yeah, thank you. So we finished up writing the report in late 2024. And it seems like a lot has happened since then, doesn't it?
Yes.
What was the expression earlier today? It's been a long week this month, or a long month this week?
Yeah, this week has been the longest month of the year.
Yeah, exactly. So it does seem like we turn around and there's something completely different in the news. But with respect to the report, we issued a laundry list of recommendations, and I think they are all still relevant today, but ways to strengthen Medicaid, ways to strengthen Medicare, also ways to improve the commercial payment system to make it function better. But then comes out the big, beautiful bill. Mm-hmm. And I think the biggest impact that folks in the emergency department community are worried about is the impact of potential Medicaid cuts.
Because I live in one of the states that had the expansion with Kentucky. There's concern that with the bill, and it's some of that's political posturing is, that 37 hospitals plus minus could risk closure. But, just as we discussed earlier today, not having coverage does not mean you don't have illness, you don't have needs, you don't end up in the emergency department. So, with those recommendations that you all put into the summary for the report, and now with the changes where we have that potential to 12 to 17 million more uninsured over the next number of years, kind of give us that where you see this in interaction with the RAND report, which is already what we were experiencing, and now with the safety net being strained even further.
Yeah, I'd say an already bleak picture has become bleaker, to be perfectly honest with you. That we worry that folks that are currently covered on Medicaid, if that goes away, they'll be uninsured. They won't have a usual source of care. So they'll show up to EDs, and then the EDs won't be able to recoup any payment for those visits potentially.
So how do we look at some of the opportunities to kind of combat that, whether it's on the federal or it's on the state level, kind of addressing some of these changes? Because we as emergency physicians, and you as practicing emergency physician as well, we're still there. We're still providing the EMTALA care that we've done since 1987 when it went into place, and we're still there serving every single patient that presents. How do we kind of move forward with that, and as emergency physicians advocate for the positive change for access and our patients?
So there's a lot that we can do. I do think it's an uphill battle for much of it, though. So I think there's still the opportunity to advocate for continued funding at the federal level and improvements in funding at the federal level. But it does seem like states are going to need to pony up at some point and really start helping out in ways that they perhaps are not accustomed to helping out.
So a big theme that we had today was really thinking outside the box. The traditional models of what we've done with Medicare, Medicaid, private insurers, clearly that is a system under stress right now, and a ton of challenges, but it's kind of giving us the opportunity to look at new strategies and new ways to do that. Kind of give the viewpoint of what you see as where we move from here with trying to adjust, whether it's on the federal or on the state level, with these changes that we're seeing.
We came across some ideas during our literature review, and one that I particularly liked came from the United Kingdom, which is described in the report as a tripartite payment model. The idea here is that still there could be a per visit fee paid by an insurance company, but that there's also some fixed fee over some period of time, let's say a month or an entire year, that helps keep the lights on, helps make sure that there's standby capacity to take care of patients who come in critically ill. But basically that there's this new stream of funding that is something like a fixed payment. And then I said tripartite, we already got the per visit, and we have this fixed payment. Mm-hmm. And then on top of that, a small payment incentive for quality. And that came across to me as an interesting option that states wanting to innovate or seeing a need to innovate to provide care to their communities could approach.
So the American tradition has always been that there's two ways things change. Is one, it completely falls apart, a disaster, the Titanic approach to things. Or the other is it gets so successful that, especially financially, that everybody starts to pull from it. You know, an example being the state I came from, grew up in, went to med school, all that stuff. They introduced the lottery. The lottery, not expecting to make a ton of money, but it was all earmarked for education. But as soon as it became successful, all of a sudden, everybody wants a piece of the action. You know, we've seen similar things with other successful programs as well. But what we see here is the fact that we're seeing the cracks. We're seeing the potential that the system is at an inflection point of not recovery. And so I think we're kind of at that beginning of the change of which we can't return without a significant revamp of the U.S. healthcare system. You talked about the British healthcare system. Australia has the blended system as well. But, you know, one of the things that we have is it's just like everything else. The U.S. system is a little bit odd for everything in for everything in the world, for that matter, because we're a little bit weird with almost everything. I mean, that's what makes America, America. The United States, is we're different. Good ways and challenging ways. But at the same time, that also means that we have a struggle kind of moving through these changes. I mean, you look at the idea that we're preaching all this efficiency. We're preaching all of these things about, you know, resource stewardship. And yet we live in an environment in which we have a zero-miss culture. And so we clearly can't promote significant resource stewardship while at the same time having a zero-miss culture. And so, you know, the report kind of dives into a lot of these things, but how do we change? How do we address these ideas when we have a system that still focuses on 60s technology and 60s legislation? Where do we go from here?
Yeah, there's a lot to unpack there, but I think that innovation is really going to become necessary. And in certain places, the cracks in the system are going to emerge first. Mm-hmm. In places, especially where there are maybe many rural emergency departments that already operate on a very thin margin, those are the places where I think we're going to start to see closures happen first, and communities become alarmed by the closures, by realizing that their access to care has been disrupted. At the same time, I think there are opportunities to provide care by different mechanisms, you know, to offload patients that might today be taken care of in the emergency department setting, but perhaps could be taken care of in other settings that could do, for example, a pre-visit evaluation, have some pre-ordered testing that could be done quickly, and then perhaps they could see a provider after that. I think these are models that are inevitably going to be explored as technology is advancing, as we have a bunch of companies trying to innovate in this space, as well as kind of a fracturing system of emergency care.
So you mentioned not only when we were talking within our conference, but also before that when we were talking, you had two examples. One that's more recent, and first and foremost, you mentioned FM radio. So, you know, the young people out there don't even know what that is. It was the Spotify of our generation. Just more shocked you didn't mention AM radio, but FM radio, you heard something there, a positive. But we also have the challenges. Both of these stories from California. One about a closure, one about a success story. Tell me why the stories are an important piece of the narrative of the advocacy in taking the RAND report and turning it into action.
So I think we do need stories in order to advocate for the specialty, and I agree that both types are important. Just on my way to the airport yesterday, on my way here, I heard on the radio a story about Los Robles Medical Center, and it was by, you know, a morning radio guy who was just telling a story about what happened to him yesterday. He said, you know, my wife got very sick. She was having scary neurologic symptoms, and I took her to Los Robles Medical Center and got outstanding care. And this is the first time I'd heard a story like this just on the news in quite a while. And I was thinking, you know, we really need to be hearing more of this so that the communities can realize the value that we're currently providing, so that once the ability to provide that erodes further, that there's this memory of this great emergency department care that they were able to obtain. On the other side of the coin, I do think the emergency department closure stories are important. In the report, there's one story also from California where One hospital closed, and as a result, pretty much everyone in the community was going to a neighboring hospital. And so they're speeding down this country road on the way to get to this other hospital. And the particular story actually that was described in the report was where a patient waited for 3 days in the hallway after being admitted for hypoglycemia, and wasn't even being fed any food or drink while being in the hallway. So these are the kinds of stories that I think need to be shared as we kind of continue to help the communities understand the value that we provide, and also what happens when our services might be taken away.
Interestingly, Ryan McBride with our DC advocacy staff mentioned that one of the biggest questions he gets when he's talking to staffers on the Hill is which show is the most accurate. And they mentioned The Pit, which is very accurate. I mean, it may be a contraction of 6 months worth of emergency medicine in one shift, but he says their response is, oh, and then, oh. Understanding really what we see in emergency medicine, in our careers, the environments, the challenges, the opportunities, the successes, the failures, the loss, the stress, the chaos, the MacGyver role of making it work. Those types of things are the parts of these stories we have to tell, because as these changes take place, we're going to be turned to more and more as a safety net. We're already seeing a majority of the acute episodes of care, but we're also the primary care for nearly half of our communities, or half of our patients. And so us as emergency medicine taking this new role and evolving, kind of your thoughts as we expand our opportunities and roles in the healthcare system. Used to be that we were just the front door, front porch. Now I think we're the front porch, yard, most of the rooms, a lot of the furniture.
Yeah, definitely all the furniture spilling out the house into the front porch. I think that we need to be involved as the care system changes. And I think emergency physicians have always been quite involved, because we do see when cracks emerge, often it does spill into our care area. So I think we need to be involved as technology is adopted in ways that may support or maybe at times undermine the quality of the care that we're able to provide. But certainly we need to be a part of the team that's there thinking intelligently about how to adopt these things. Fun fact about The Pit. 2 of our nurses in the ED at Cedars-Sinai are on the show. So not only do I see them in the ED, I see them on TV.
Oh, so it's just like a continuity of care. I mean, that's what people ask me. They're like, have you watched? It's like, well, I can't watch it after the end of a run of shifts.
Definitely
because now I feel like I'm back at work again. And so I have to do it when I'm completely disconnected from emergency medicine, traveling, doing whatever, going to a race. I'll watch a couple of episodes while on the airplane or whatever. But it's that idea of kind of that crossover of entertainment, reality, and they still say, and they will say it at Scientific Assembly in Salt Lake City, that they understand the 3 things they got wrong are charting, which I thought the last 4 episodes were just going to be charting. They've lost the whole audience at that point. They don't wear masks because you can't do drama with masks. And the other was the administration coming down to the emergency department and having interest in what's going on down there. And so those 3 things you're missing out. The rest of it is just right. How can folks tell everybody access to the RAND report that we're talking about, kind of the take-home message, and we'll put a bow on it?
Yeah, so you can access the RAND report on the RAND website. I'm sure you can also provide a link from the notes here. And it's called Strategies to Sustain Emergency Care. Basically, the first chapter talks about the value that we provide to society, patients, also government, as well as payer stakeholders. Then we go into all the challenges facing our specialty. We do a deeper dive into the issues related to payment. And then we come up with some recommendations about how to sustain emergency care, which many of which involve payment, but also address a lot of the other challenges that we discuss in the report.
And it was very emergency medicine based once you get through the 167 pages.
Yep.
It's the fact that there is a list at the end that mentions the steps and the things, and I've actually used those on interviews that I've done, as well as TV segments as well, kind of wrapping up some of those easy recommendations from the report on ways we can make sure we strengthen, stabilize at least, the access to the safety net of our healthcare system. I appreciate you coming in. Thank you so much. So Dr.
Thank you.
Carl Berdahl. By the way, I couldn't say the name this morning when we first did the interview with Dr. Abir. I could not say it. It was too early, had not had enough coffee. So thank you for being willing to be here in the afternoon when I'm fully caffeinated and ready to pronounce most of the name.
Thank you. And Dr. B works too.
Yeah, Dr. B. All right, so hanging out with Dr. B. You heard earlier Dr. Mashid Abir and talking about the update on the RAND report, how things have changed with regard to the big, beautiful bill, politics, advocacy, all of those things in between. Feel free to contact me, rstanton@acep.org, rstanton@acep.org, or at EverydayMed on X. We're also available on all your other platforms, including Instagram, so check us out, follow along. Got the feed here, you got the video, you got the audio. Make sure that you're subscribed to the podcast, that you're getting every weekly episode. And until next time, I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.